Morning. Can you hear me and see me?
Yeah, good morning.
Good morning. In 1 second here. First, any questions or concerns? Any questions? So we have today and we have next Friday. We're going to finish chapter 16 today and get a good jump on chapter 11. And that will be the last chapter.
I saw that there was like a chapter 15 practice. That's not something we have to do.
It is something you have to do. We did cover chapter 15, right?
I have 14 and 16.
We didn't cover chapter 15.
I don't think so. Let me see. We went from 13, 14 to 16.
I have some recordings of it. If we get to it, we'll get to it. You are responsible for it. Shoot. I have some recordings. They're posted. Work to look at them. It's a short section. And you'll see the recordings for the whole chapter, about an hour and a half. Let me.
I think that's what you had said before we, the week
Did I
before
say that?
Thanksgiving, was
Okay.
that it was a short chapter and that we were going to go right from 14 to 16.
Okay.
And that maybe you were thinking about after that coming back real quick to 15 or something.
Let's do that. If I don't get a chance to get to it, it is a recording of chapter 15.
Okay.
You're right. I don't remember actually doing it. I remember saying that in one of my classes, and of course I can't remember which one. But they're posted. Let me show you where they're posted actually. Where I say that.
Leave the cat alone.
Somebody's doing some disciplining.
Yeah, I'm in here and the cat was by the tree and I could hear just a battle going on between the two of them. I'm like, Jiminy Christmas. It doesn't help when you don't feel good and you have to deal with this. I'm like, come on.
You got to stop cussing like a sailor over there. You're gonna, realize you're being recorded while you're cussing like that.
Oh yeah, that's right. I'm sorry.
Did I Yeah, so here they are. These are the two recordings. Between the two of them, this one I think is about a half hour. This one is about an hour. Between the two of them, they take up about an hour and a half. Let's finish chapter 16. Let's move into chapter 11. And then, yes, let's see if we can get back to it next week.
Sounds good.
So special senses, I think we were on slide 6. So normal hearing conversations have an average loudness of about 60 decibels. So about right here. The threshold, the pain threshold in hearing is about 120 to 140 decibels. Prolonged exposure at above 90 decibels can cause damage to the ears. Three basic parts: the outer ear, the middle ear, and the inner ear. The outer ear includes the auricle or the pinna and the ear canal. Do you remember what bony marking makes up the ear canal? You've been talking with Dr. Weeks about the bony markings. Do you remember what bony marking makes up the ear canal? It's the external acoustic meatus. If you think external meaning on the outer side, acoustic because that's what sound is. Meatus meaning a canal. So the external acoustic meatus. The middle ear is composed of starts at the tympanic membrane, the eardrum, and includes the 3 little ossicles in this middle tympanic cavity. From the middle ear, there's a tube called the auditory tube or the eustachian tube that drains into the nasopharynx, the back of the throat in the back of the nasal cavity. So from the middle ear. The inner ear includes the cochlea and the semicircular canals and the vestibule. And this vestibule cochlear nerve, do you remember which cranial nerve that was? The vestibule cochlear nerve. I know it's been like 2 weeks. If you go through one of your mnemonics, let's see, on, they traveled and found Voldemort guarding very ancient Horcruxes. It's a vestibular cochlear nerve. And it is actually inserting into the inner ear via the internal acoustic meatus. So you have the external acoustic meatus, then you have the internal acoustic meatus. So inner ear, middle ear, and outer ear. The outer ear and the middle ear are concerned with the functions of transmission of the sound vibrations. You remember we have these sound wavelengths where it's a rhythmic compression of the air. And when that hits the tympanic membrane, the tympanic membrane starts to vibrate at that same rhythmic compressions. The inner ear is involved in converting those vibrations to nerve signals. The outer ear, the pinna or auricle, directs sound waves into the ear. It works like a funnel to direct sound waves in. Within the external auditory canal or the external acoustic meatus, there are actually, I'm saying it wrong. My mother just ceruminous and sebaceous glands that with dead skin cells produce cerumen. What's cerumen?
So earwax?
It is, good job. Earwax. So that's a scientific anatomical term of earwax. Sounds a lot better though. Cerumen. With the guard cells, it protects the outer end of the canal. So I think I mentioned I've struggled with my hearing the majority of my life. It was diagnosed when I was about 18 months old that I had a hearing loss. And it's a unique type of loss, and we'll talk about it towards the end of this chapter, just exactly what type of loss it is. But one of the things that I've learned about it is the function of earwax and what its purpose is. If you've ever smelled earwax, it's one of those things that you don't forget what it smells like because it stinks so bad. And its function is an immune response. It prevents things from taking up residence in your ear. If you think about it, your ear is this warm, moist, internal cave. And it would be an easy place for bugs, little tiny termites, little whatever, little parasites, maybe a good yeast infection, to find a really good spot within there and take up residence. And the one thing that prevents them from taking up residence, or one of the things that prevents things from taking up residence, is that the earwax. And so as I told you, I've struggled with my hearing, and I just turned 48. And so I've had a hearing aid since I was probably about 32, off and on. And the only hearing aids that work for me are the ones that are completely in the canal. Let me go grab it just a sec.
Finley.
The only ones that work for me, and I'm I go off and on. I only wear it when I want to wear it. And so I wear it when I teach in the classroom, but I don't wear it at home. And the reason I don't wear it when I'm teaching at home is because sounds within the house will distract me. So it's about this size. It's just a little bigger than a dime. It's maybe a little bigger than a nickel. And this is my most recent one. This is one of 3 that I've gone through. And I got this one this last summer. If you're looking for a hearing aid specialist, I can recommend a great one to you. But I can tell you that it's one of the more out next to my car. It's one of the most expensive things I own. It was $3,500, and I'm paying on it right now. And the reason I bring it up is because the over-the-ear hearing aids don't work for me. When we've tried them every time, and the only thing that they help me do is hear my hair better. And I can tell you that gets to be really annoying really fast when the only thing you're hearing better is your hair rustling by your ear. But so I started wearing this. And the one thing so I explained that the earwax works to prevent things from taking up residence in your ear canal. Well, when you wear a hearing aid that's in the ear canal, your ear, it's doing its job as an immune response, and those guard cells and guard hairs think that your hearing aid is something that's trying to take up residence in your ear. And so, and of course, it's not going away. You keep putting it in there off and on. And so as a result, my ear, especially the one ear that I wear it in, my right ear, I tend to develop more earwax in there than normal. And infections will cause outer ear infections, because as a result of wearing a hearing aid that didn't fit very well, I ended up actually getting an outer ear infection. And it was pretty bad. Whenever I would wear my hearing aid during that time, I could smell the earwax in my ear. And I can tell you that's really disconcerting. When you're sitting there in a meeting and you can actually smell your ear. But the one thing, so it's your ear's way, your earwax is your ear's way of protecting your ear. And it actually can damage my hearing aid because the earwax can ruin it. And so I work really hard to keep my ears fairly clean. But I just know that that's my ways, the way of my ear trying to protect my ear is this cerumen buildup. And if you get an outer ear infection, an infection in this area, you'll develop even more earwax because your ear is trying to prevent infections. And that's its way of doing it. So the tympanic membrane, the outer ear includes the pinna, the auricle, all the way to the tympanic membrane. The tympanic membrane vibrates in rhythm to the same wavelengths as the sound wavelengths. So keep that in mind for a second here. It's vibrating once the air starts being compressed and we start getting those waves of air moving into the ear. the ear starts to vibrate at the same wavelength. The tympanic membrane starts to vibrate to the same wavelength. The middle ear, or the tympanic cavity, contains ossicles, meaning small bones that amplify sound waves and transmit the sounds to the inner ear. The malleus, or the hammer, has its handle actually attached to the tympanic membrane. And when the tympanic membrane starts to vibrate, the handle of the malleus that's attached to the membrane starts to vibrate at the same rhythm. The tympanic membrane is highly innervated. It's innervated by the vagus and the trigeminal nerves and is highly sensitive to pain. Pressure and stretch of the tympanic membrane because of fluid or pressure buildup within the middle ear can be extremely painful. It's another immune response to prevent things from injuring your ear. The other three bones, the other two bones, the malleus, the incus, and the stapes. The stapes is attached to the oval window via its foot plate, to the cochlea. The eustachian or auditory tube is a tube that drains from the middle ear into the nasal pharynx, the superior part of your throat or pharynx that is right behind the nasal cavity. Swallowing or yawning will allow for equalization of the pressure on both sides of the tympanic membrane, equalizing the pressure within the middle ear. Why is that important? If you have ever flown, and I know that some of you have children. If you've ever flown with children, what do they recommend you do when you're changing altitudes?
To try to like swallow really hard and like pop your ears so they can
Yep.
keep equalizing.
Yep. They were, say it again. Chew gum.
That's what I was gonna say. Give them gum.
Yeah, that and gum.
And when they're babies, what I've seen on planes is people give them a bottle at that moment. They choose that moment to give them a bottle because it gets them to swallow and yawn to equalize that pressure. I know what they're for, but so don't get rid of them. You don't need to put them in there, but don't get rid of them. Okay. So I know from experience and from talking with other friends who struggle with ear nose issues is this doesn't work so well in us. We can't equalize the pressure very well. I realized after talking with some friend, I have a friend who got, I think I probably didn't talk about her. She got the tip of her nose torn off in a trampoline accident when she was younger. And if you can imagine that, she got her nose caught in the trampoline springs.
Oh my.
And she says she doesn't remember it hurting at all. She just remembers there being a lot of blood. But since then, when she flies, her ears will actually start to bleed. And she'll deal with such a high pain level to the point of where they'll rupture and they'll bleed. And what's happening is her tympanic membrane is rupturing. And I've know other people who I've heard tell me the same thing, that when they've flown there, a lot of times they'll start draining blood from their ears. And I realized when I started hearing these stories that I had absolutely nothing to complain about. Because yes, I can deal with a lot of pain when I'm traveling. I've learned prophylactically to start taking pain medication. And then I don't deal with the pain of my ears. But I've never had them bleed. And what's happening, is the tympanic membrane, in response to such high pressure changes and not being able to equalize the pressure, is rupturing to release the pressure or cracking. But why do other reasons we care about this? This is the reason that babies are much more prone, and younger children are much more prone to ear infections. Ear infections are a fluid buildup of fluid buildup in the middle cavity of the ear, middle ear. Why is this the case? Why do we not see it so much in adults? Is in children, as before their face starts to elongate as they become older, the auditory tube is more horizontal. In adults, it's more vertical. And as a result, it drains better in adults. Any fluid buildup in your middle ear will drain better as an adult than it would as a child. And I can honestly say that I can't remember. I do know what it's like to have your ears not have increased pressure in your middle ears when you're flying. And I know that pain is terrible. It's really, really awful. I know I found myself in fetal position sometimes when I've been flying because it hurt so bad. And people are wondering what's wrong with you, and you're trying really hard not to claw your ear out because it hurts so bad. But I can imagine that ear infections feel that same way. I know, I've never had children, but I've heard about ear infections, and I can imagine that they'd be exceptionally painful.
I have a quick question. Would the way that the children's eustachian tube is, of course, more horizontal and kind of more squished before they fully
It's
grow?
actually normally pretty squished. It's normally a pretty flat canal.
Oh, okay. Would that have anything to do with kind of like why babies are so like maybe more snotty than adults? Because that would go to the back of like drain towards the back of your throat, right? So like would that have anything to
Let's ask my mom that one. Ask it again right there.
So I wanted to know if that tube would have, like in babies,
Because of the changes.
and it does kind of drain towards the back of the throat, if that has anything to do with perhaps maybe why babies can be more like snotty.
No, they're just more snotty to keep you entertained.
That's what I was gonna say. They're
Well, and they're not as good at sniffing their nose, we do it automatically and they don't.
Yeah, that is true. Okay.
Yeah.
Yeah, I was just thinking about that. I was like, well, I wonder if there's like a slight excess like buildup of stuff. I don't know.
Cerumen?
No, just not coming
Just
out of
not-
their
oh.
mouth, going-
Oh,
coming out of
mucus,
theirs.
mucus.
Yeah.
No, it's just, they just have that mechanism that protects their nasal passageways and your airways.
Okay.
It's working, but they're not as good at managing it.
Okay.
Okay.
They just do it to keep you warm. Got it. Oh, that's funny. I've never really thought about that. So otis media or middle ear infection, common in children, where the auditory tube is short and horizontal. These ear infections can easily spread from the throat to tympanic cavity to the mastoid air cells. If you think your mastoid process back here has air cells in it that can become inflamed with an ear infection. If you think your mastoid process is right behind your ear. Symptoms: fluid accumulates in the tympanic cavity, causing pressure, pain, and impaired hearing. I know that when I'm dealing with a cold, I hear less than I do normally. And I can definitely tell a difference between when I'm dealing with a sinus infection or allergies that are affecting my hearing. It can spread, leading to meningitis. Another symptom of chronic ear infections can cause the fusion of the ear ossicles or otosclerosis and a hearing loss. I know that I have this otosclerosis in at least my right ear. Whether it's in my left ear or not, we don't know, but I know it's in the right ear, and I'll explain why in a moment here, how I know that I have it. But what that means is that the three little bones, the malleus, the incus, and the stapes, are partially fused together. So they don't vibrate the way they should. A tympanostomy, you've probably known children who have had this, or even have friends who have children who have tubes in their ears. What this is lancing of the tympanic membrane, and many times all they have to do is lance the tympanic membrane. Other times they lance the membrane and insert a tube. And this just helps with draining the fluid from the tympanic cavity. I remember recently talking with a student who never had to have tubes inserted, but they would periodically go in and lance the tympanic membrane. So tubes in the ears, or this tympanostomy, is essentially making a small hole in the tympanic membrane and inserting a tube. Eventually the tube falls out. But your eardrum normally looks very, very, very smooth. A very, very smooth structure. And if you look right here, you can see the handle of the malleus attached to the tympanic membrane. If you go onto Google and look at pictures of eardrums, you'll see it on other eardrums too. Well, you'll actually see the handle of the malleus attached. With my hearing issues, and especially as I've started to study anatomy and physiology, when I go in and have my ears looked at, I like to ask I like to ask questions. And one of the things that my first hearing aid specialist was able to do was go in and show me. He took a camera and inserted a little mini camera and inserted it into my ear canal. And on a TV setup, showed me what my middle ear looked, my tympanic membrane looked like. A scar, my mother says, a scarred up mess. And she's right, because when I looked at it, the one thing is and let me explain the story. I dealt with chronic ear infections. And I don't know when I started getting them. Mom, do you remember? Okay, so I told you I had ear, nose, and throat issues. I had a cleft palate, cleft lip and palate. And a lot of times it went, because if you see a lot of ear doctors, they're not just ear doctors, they're ear, nose, and throat doctors, because of the connection between the three. And what they started doing, and I know that I had at least 5 sets of tubes put in my ears. And they would put them in, they would stay in for a while, and then they fall out. And then if you need them again, they reinsert them. And by the time I was about 13, 12, 13, I know I was in the 8th grade, was starting the 8th grade. They realized that, first off, they were going to quit doing tubes at that point. And when they decided to quit doing them, normally this little hole that they've made to insert this tube just grows over, just smooths over and heals up, just like a cut would. But in my ears, because I've been having tubes for so long, rather than having the hole just heal up, it started to grow out. What happened was the last set of tubes you got, they put in larger ones because the smaller ones came out so quickly. Okay, explain this to them. I didn't know this.
They usually put a little teeny tiny one in there, and they will, and hopefully they'll last. But her ears would work well. It's a foreign body, so your body wants to get rid of it, and so hers would come out, more quickly than they were ready for them to. So they put in larger tubes this last time, and when the one came out, instead of the whole healing, it eroded all the way back. So she had no tympanic membrane at all.
I didn't realize that.
Yeah, it was gone.
I thought that I didn't realize it was completely gone. And so as a result, they went in and grafted an eardrum there. And so with my first hearing aid specialist and him inserting this tiny camera into my ear, I got to see what that looked like. And I all I can do is tell you it looked really kind of funky. Like it wasn't smooth, and it just looked kind of interesting. And when they went in and grafted that new eardrum in there, the tympanic membrane, they saw that the 3 little bones were partially fused together in that ear. Whether or not that's the only reason for my hearing loss is that they're partially fused, or if it's a combination of the eardrum looking pretty funky. It could be a lot of different things. But what I have is what they call conductive loss.
I have a question.
Go ahead.
If you have like a constant popping in your ears, is that your tympanic membrane?
I'm guessing it is. Mom, if you have a constant popping in your ears, is that your tympanic membrane?
It is.
It is.
Yeah, and it's just the pressure equalizing.
It's just the pressure equalizing. Does it hurt?
No.
You're good. As long as if it doesn't hurt. So moving on, the inner ear, a tube within a tube structure. The bony, what you have is a bony labyrinth, a circular, sometimes shell-like tube. And then you have some tubes that are shaped like semicircular canals. And these are built into the temporal bone. Within this bony tube, you have a membranous tube. So fleshy tubes that are lined with a bony labyrinth. So it's kind of like a bicycle tire. You have the outer tube, and then you have that has the traction on it, and then you have the inner tube within it. So the fleshy tubes lining the bony labyrinth. The inner tube is filled with endolymph, which is similar to intracellular fluid. The outer tube is filled with paralymph, which is similar to cerebrospinal fluid in its texture. So we have this outer tube, and then we have an inner tube. The blue is the inner tube. The outer tube is the green. The cochlea is the organ of hearing. It coils around a screw-like axis of spongy bone, or modiolus. Modiolus, I think that's what it's called also. And then you have a vestibule and semicircular canals, with each of these canals being in one of the dimensions of space, one of the 3 dimensions of space. The vestibule and the semicircular canals are your organs of equilibrium and balance. Within the cochlea, there's 3 chambers. The middle chamber is the cochlear duct. This middle chamber is also called the scala media. It's separated from the scala vestibuli, this upper layer, this upper chamber, by the vestibular membrane. The bottom duct is called the scala tympani, or basilar membrane. The middle chamber contains the organ of Corti, the spiral organ, which is your acoustic organ, which is the one directly involved with converting the vibrations into nerve impulses. Within the scala tympani, there's an epithelium composed of hair cells and supporting cells. Here's your organ of Corti. If you think about an organ that they play on that's similar like a piano, think of it that same way. Has multiple layers, multiple sets of keys that are involved in the precision of the sound. So the epithelium is composed of hair cells and supporting cells. These hair cells, so this is a magnification of this. These hair cells, there's 4 rows, 3 outer hair cell rows and 1 inner hair cell row. Each of these hair cell have little stiff microvilli hair that are called stereocilia on their apical surface that are embedded in the tectorial membrane above. And this tectorial membrane is like this gel-like membrane, gelatinous membrane. If you want to think of it, it's like Jell-O. It's like very, very stiff Jell-O. You've seen like Knox blocks where they have more gelatin in them than typical Jell-O. It's got that same consistency. So keep all this in mind as we keep talking about this and keep opening up this story about how you learn how you hear. So the gelatinous membrane rests on top of the stereocilia. And the tips of the cilia are partially embedded in this tectorial membrane, this gelatin, stiff like gel sheet. The 3 outer rows of hair cells that are composed of about 20,000 cells adjust the response of the cochlea to different frequencies, like cochlear tuning. If you have a piano, you're used, or if you've played any string musical instrument, you know how you have to tighten certain strings and loosen other strings and so forth to get just the right sound. That's what these are involved in. So they're increasing the precision of the sound. So they're up here, and if you notice, if you can see this picture pretty well, zoom in just a little bit more. If you look at it, they're a little higher up than the inner hair cell row. The inner hair cell row has about 3,500 cells in it, and it's what actually provides the hearing. So just to summarize, have the scala vestibuli that contains perilymph, have the scala tympani that contains perilymph. Within the cochlear duct, the scala media, there's endolymph. And within the cochlear duct on the bottom level, sitting on the basilar membrane, which is the roof of the scala tympani, is this organ of Corti. And in this organ of Corti, there's 4 rows of hair cells. The first 3 are in front, and they're a little elevated. And then there's one row that's a little lower. The top 3 adjust the tuning, adjust to certain frequencies. The lower inner hair cell row is involved in creating the action potentials that are going to result in the nerve impulses that we recognize to be our hearing. So 3 inner hair cell rows, so 3 outer hair cell rows, 1 inner hair cell row. And it's sitting on the basilar membrane. Down here is the scala tympani, and it's filled with perilymph. Up here is the scala media, which is filled with endolymph. Now, looking at this as a whole, coming back to looking at the middle ear, the tympanic membrane has an area about 18 times that of the oval window, which is where the stapes is attached to the cochlea, which contains the cochlear duct. The ossicles concentrate the energy of the vibrating tympanic membrane onto the oval window. Moreover, the ossicles and the muscles that are attached to the ossicles, the stapedis and tensor tympani, have a protective function against high pitches and high loud sounds. If the sound level gets too high, these muscles will pull back on the ossicles. This is what we call the tympanic reflex. Remember, all of your reflexes, almost all of your reflexes, have some sort of protective response. It's a protective function. They work to lessen the transfer of energy into the middle ear. So that's what this reflex does. If there's too much energy in those air wavelengths coming into the ear, they work to lessen it by pulling back on the ossicles. So the vibration in the ossicles causes pressure waves in the perilymph of the middle ear, of the inner ear. Here we have the tympanic membrane. It's beating in terms, the wavelength is moving in terms of the tympanic membrane, and in response to the wavelengths of air coming in. Now, because it's vibrating, the malleus and the incus and the stapes are vibrating to that same rhythm. And because the head of the stapes is attached to the oval window, it's vibrating to the same rhythm. And now, because we've got this transfer of movement, the fluid, the endolymph within the scala tympani is vibrating to that same wavelength. With that in mind, that's what's creating the vibrating endolymph is what's causing pressure waves in the inner ear. The movement of that endolymph, it's vibrating, is causing vibration of the overlying basilar membrane. And the hair cells are laying on top of the basilar membrane, and with the basilar membrane vibrating, the hair cells are vibrating also. They're moving up and down. Remember that the stereocilia are embedded in the tectorial membrane. So they're vibrating in wavelength. And so now the tectorial membrane, the hair cells that are moving up and down are now partly embedded in this tectorial membrane, this gelatinous substance. And as a result, they're getting pushed and bumped up against the tectorial membrane. Boom, 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 boom. And as they get bumped up against this tectorial membrane, they have those little stereocilia on the top that have mechanically gated channels that are opening in response as they get bumped. With that in mind, there's a high potassium endolymph up here. That's what this solution is up here. It's high potassium, creating this electrochemical gradient. Outside of the cells is plus 80 millivolts. Inside is minus 40. As those hair cells get bumped, they have mechanically gated channels that are opening as they get bumped up against that tectorial membrane. The top row, the first row, has a tip link that connects that row with the next row of gates, with the next rows of gates. And so the tip link connects one ion channel to the sidewall of the next. And so as the tallest stereocilium is bent when the basilar membrane rises up to toward the tectorial membrane, it pulls on the other channels via the tip link, opening them up. So the tallest stereocilium is bent towards the tectorial membrane. It pulls on the other tip links and opens up ion channels. As a result, potassium flows in. Remember, it's a potassium-rich outer environment. And depolarization causes the release of neurotransmitter, which stimulates the sensory dendrites and generates action potentials in the cochlear nerve. Any questions? How do you determine this? How does your brain determine the softness or the loudness of a noise and the pitch? Variations in loudness or amplitude cause variations in the intensity of the cochlear vibrations. This is that same tube that's rolled up as a shell. straightened out. Soft sounds produce relatively small motions in the basilar membrane, just tiny bumps. Louder sounds make the basilar membrane vibrate more vigorously. Boom, 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 boom. Triggering higher frequencies of action potentials. The brain interprets this as being a louder sound. The pitch depends on which part of the basilar membrane vibrates. The part of the membrane, basilar membrane, that's closest to the oval window is narrow and stiff. And when it vibrates, the brain interprets those signals as being higher pitched. At the distal end, where the membrane, this basilar membrane is 5 times wider and more flexible, the brain interprets the signals as being lower pitched. Any questions? The sensory pathway includes 4 neurons, four pathways of neurons. The first order is axons that run from the cochlea to the cochlear nuclei in the medulla oblongata. The second order includes axons that travel to the superior olivary nucleus in the pons or the inferior cochlea in the midbrain. The third order contains axons that travel to the thalamus. And from the thalamus, the fourth order carry those signals to the primary auditory cortex. So the first order carry those signals from each of the cochlea and synapse on second order neurons in the cochlear nuclei on both sides of the medulla oblongata. Right here to the medulla oblongata. The second order neurons take one of 2 pathways. Some ascend to the inferior colliculi in the midbrain. Remember, those are part of the corpora quadrumana. So this is where we get our auditory reflexes, where your startle reflex in response to a loud noise. Or you look, when you hear a loud noise, your head automatically turns that direction. These are all mediated by the inferior colliculi. Another pathway of the second order neurons can take is they can ascend to the superior olivary nucleus in the pons, which is involved in binaural hearing, where signals from the 2 ears compare how long it takes for the wavelengths to reach each of those 2 cochlea. On this side or this side, which one takes longer? That's how you determine where a noise is coming from. I can tell you that being hearing impaired in a classroom, a lot of times I can't tell who's talking to me because I can't localize the sound. My students, I'm pretty honest in a classroom, and I just tell my students I'm hearing impaired. And they recognize that, and we get along just fine. But they also have to be patient with me when I can't, when it takes me a minute to realize who's asked a question in the classroom. So signals from 2 ears are compared to help localize sound. Protective sound dampening. Efferent fibers are sent to the tensor tympani and the stapedis for that tympanic reflex to prevent damage to your hearing. The third order neurons begin in the inferior colliculi and synapse on fourth order neurons in the thalamus. Remember, the thalamus is your gateway for sensory. Those axons from the thalamus travel to the primary auditory cortex at the superior margin of the temporal lobe, allowing for the conscious perception of sound. So two forms of hearing loss deafness. Conductive deafness, conditions that interfere with the transmission of the vibrations to the inner ear. This is what I deal with. When there's been a damaged tympanic membrane, ear infection, or blockage of the auditory canal, not the auditory tube, but the auditory canal, and otosclerosis, fusion of auditory ossicles that prevent their free vibration. So it's an issue with the conduction of the sound, not with the nerve reception, nerve sensitivity. Sensorineural or nerve deafness is death of the hair cells or any nervous system elements concerned with hearing. I have this friend that got her nose torn off in the trampoline accident. Also had a rare autoimmune disorder that attacked her hair cells in her ears. And so between the ages of 5 and 18, she lost the majority of the hair cells in her ears. And so she learned to speak before she went deaf. But she still, every once in a while, she'll say a really odd, weird, and I'll kind of look at her like, what? And she'll realize that she's saying it wrong. And she, it's been really interesting. She was my partner in crime studying anatomy and physiology. She was one of my first sets of students, and she can tell you she hated me. But she told me about this rare autoimmune disorder that she dealt with that attacked her hair cells. And so any word that she learned before she was 5 years old, she pronounces perfectly. When she learned anything she learned after that age, she sometimes struggles with pronunciation. And I've noticed, like, she being one of my partners in crime with anatomy and physiology, she will struggle with pronunciation. And when she says something funny, I'll look at her like, what? And she's like, okay, I'm not saying that right. And then she gets trained how to say it right. And she'll sit there and when you try to help her to say it right, she looks at the way your mouth is shaped. She looks at the way your tongue is shaped and tries to imitate what you're doing. And that's the way that she learns how to pronounce things right. let's, first, any questions? Let's take a 10-minute break right here and come back and we'll go over balance and start the muscle.
Sounds good.
Yeah, whatever. Whatever. Okay, you ready to go back? Come on, Mrs. Mom, would you take Paisley out? Do you need to go out? Maybe. If she starts to lick me. Go outside. Thank you. I didn't do it. You did it. Okay, let's move back into this. So ear and balance or equilibrium. Ear is important for the ear is important for the maintenance of balance. Just like how fluid vibrations in the ear are interpreted as sound, fluid vibrations in the vestibule and semicircular canals are used to sense changes in equilibrium and balance and acceleration. So we have ciliated equilibrium sensory receptors located in what are called the utricle and the saccule, here and right here, that sense tilting of the head and body. Semicircular canals will sense rotation. Remember that the semicircular canals are, each circular canal is in one of the three dimensions of space. So different types of equilibrium. The vestibule and the macula within the vestibule contains receptors that flow or are partially embedded in an otolithic gel. I think Becky mentioned a couple of weeks ago about having what was it, Becky?
They said they were realigning my crystals in my ear.
So what they were doing is they were realigning these otoliths.
Yeah.
And so the crystals, that's the right term. They're little crystalline rocks. And otolith means rocks. And so it's like a gelatin rock, like it's a gel that has a lot of rocks embedded in it. As the head is upright, this gel, and we just got over Thanksgiving. So if you think about it, it's like we have a plate in front of us, and on this plate, we have a gel or jello. And as the plate moves one way or it moves the other way, the jello slides from one side of the plate to the other side of the plate. And within the plate or within the solid surface, there are embedded little receptors. And as the jello slides from one side to the other side, it opens mechanically gated channels within those receptors. That's what you sense, what's going on when you sense that your head is being bent forward or it's being moved back up. Is that gel is moving up from one side to the other, and it's just sliding across these receptors.
What is the gel and the crystals like made of?
Oh God, you're asking me, I should know this. I don't know. I'm trying to remember. I learned at one point the otoliths, I think they're calcium crystals.
Okay.
I don't know what the gel is made out of. It's I know it's in your book.
Okay.
You want to ask me any more questions that I can't answer? It's a good one. I can't remember.
Okay, no, that's fine. I can look it up then too.
I think they're magnesium or calcium crystals.
Yeah. So this is interesting. Would this have anything to do? So I don't have equilibrium problems, but I did have to go to an ear, nose, and throat doctor because sometimes I was having like this intense, like in my right ear, like a pounding, swishing noise. And it was almost like I could hear my own heartbeat, but it would happen like seasonally, like when I know this sounds crazy, but like when the weather was really changing. And it has kind of gone away, but I know that sometimes when I do get it, I have to like kind of like tip my head and hold it in like a weird way so that I can stop like hearing it. And I wonder if this is, I don't know. I wonder if that's it. Like if it has anything to do with that. Or if that's
Mom?
If it's a position from the FD maneuver, yes, it has a lot to do with it.
No, she's never had have you had the Epley maneuver done?
No, I've never had that done. Like what Becky had?
Yeah.
Yeah, no, I've never had that done.
It could be that it's functioning that same way.
Yeah. Okay. That's
I'm looking up, you asked about that otolith, and I'm actually looking it up because they're calcium crystals.
Yeah, that's what they told me. The PT told me.
Okay.
oh, okay, cool.
Okay, calcium carbonate structures. I don't know what the gel is, but they're calcium carbonate structures. Dynamic equilibrium angular acceleration. This is a semicircular canals or crista ampullaris receptors. So here it's a layer of hair cells, just like we saw in the cochlea. here it's a crystallized little knob, a little gelatin knob that gets bumped and nudged, called the crista ampullaris. With regards to static equilibrium and dynamic equilibrium, when the head is tilted, the heavy otolithic membrane sags, bending the stereocilia and stimulating the hair cells. So it just kind of slides on top of it in response to gravity. Dynamic equilibrium. The otoliths lag behind, bending the stereocilia and stimulating the hair cells. All of a sudden you start going really fast and that membrane slags behind it. It kind of gets dragged a little bit. The saculi is nearly vertical and it responds to vertical acceleration and deceleration. You've been on those rides where they, at fairs, where they drop you all of a sudden. I can say that I don't like those rides.
Me neither.
But they drop you all of a sudden. That's what's being sensed within the saculi. The semicircular canals detect rotary movements or angular acceleration. Within the ampulla, there's this ampullaris crista, crista ampullaris. The ducts are stimulated by rotation in the different planes. Each duct is filled with endolymph. So just like we saw in the cochlea. And the endolymph opens up into a dilated sac next to the utricle. And within the ampulla is this crista ampullaris. So the hair cell, this crista ampullaris, is buried in a mound of the gelatinous membrane called the cupula. And as the fluid moves across the surface of the ampullaris, it bends it. Or it can bend it the other way, opening the different channels. So as it gets pushed over, the cupula gets pushed over, it stimulates the hair cells. You've done this, you've seen this more than a few times. We were talking about little kids before. You know, one thing that will make up for the snotty noses is when you get to spin them around. So you grab a little kid by their hands and you say, let me spin you. And of course they think it's great and you think it's great. So you start spinning them and spinning them and spinning them. And then you put them down on the ground and tell them to walk straight. And it's really funny because they can't do it. That's because of the crista ampullaris. Fluid is moving over it's moving in such a way that it keeps bumping the cupula, opening up the gates, letting action potentials through. And actually, let's stop right there for 1 second. We've got a video here.
Grammarly does more than catch errors. With Grammarly, you can find really good, no, perfect words. This picture here is a picture of a semicircular canal and its ampulla. This ampulla is depicted right here. And the ampulla, inside the ampulla of the semicircular canals lies the most important part of this. It's what drives our detection of dynamic movement. And that would be the capula. The capula is this gelatinous mass here that encases the hair cells, which are responsible for contacting the vestibulocochlear nerve and telling us that we're undertaking some kind of dynamic movement. Now, the only way that those hair cells contact the vestibulocochlear nerve and tell you that you're undertaking some kind of dynamic movement is when the capula is actually bent from side to side. And the way that that happens is by making some kind of dynamic movement. When you make some kind of dynamic movement, there is a fluid inside of the semicircular canals that circulates through and pushes that capula from one side to the other, depending on what kind of dynamic movement you're making. So when that happens, the capula gets pushed to the side, and say we're pushing it to the left here. And when that happens, it contacts the vestibulocochlear nerve and says, oh, you're doing such and such dynamic movement. Keep in mind that there's 3 different orientations of semicircular canals, and they're on both sides of the head. So they're not just in the central portion of your skull. They're on both ears. And when you turn one way, both of the semicircular canals are contacted and they're moving. This is how you detect dynamic movement. Now let's look at how to tie in the semicircular canals with the brain, specifically the midbrain, where you find the corpora quadrigemina. The corpora quadrigemina are responsible for helping you track moving objects. So when you're undertaking some kind of dynamic movement, these semicircular canals actually...
I'm going to stop it just for a second. Some more of this. So the receptors get opened. They signal action potentials. Where does that information go? Where do the action potentials, where are they reached? One of the first pathways is the cerebellum, which integrates vestibular information into its control of muscle tone and posture. It integrates both head and eye movement. You do this all the time, whether you realize it or not. Your vestibular pathway, you're driving down the road and you see a street sign coming up. You see the stoplight coming up. And before you reach the stop sign or the stoplight, you start to brake. And while you're driving and you're moving forward, you're keeping your eye on the stoplight. This is integrating head and eye movement. Keeping your vision fixed on a distant object while moving towards it or moving away from it. So being able to keep your eye on it while moving away from it or towards it. Called the vestibulo-ocular reflex. Reticular formation, adjusting blood circulation and breathing to postural changes. Remember, this was your consciousness. Your spinal cord descending to 2 vestibulocochlear spinal tracts of the spinal cord and innervating extensor anti-gravity muscles, keeping you from falling over and giving into the forces of gravity, keeping you upright, even with the force of gravity. The thalamus is the relay station to the cerebral cortex for awareness of position and motor control of head and body. One last thing that I'm trying to think, I missed it in here. Your inferior colliculi are involved in helping you maintain your eye movement as you're moving. Involved in keeping your eye on an object as you're moving towards it. Within mind, let's watch the rest of this video here.
Contact those corporeal
So I'm going to back up just a little bit.
responsible for helping you are contacted and they're moving. This is how you detect dynamic movement. Now let's look at how to tie in the semicircular canals with the brain, specifically the midbrain, where you find the corpora quadrigemina. The corpora quadrigemina.
Where was the corpora quadrigemina? Those 4 bumps, the superior colliculi and the inferior colliculi. The superior colliculi are involved in visual reflexes. It's going to be important right here. Remember, the inferior colliculi are involved in auditory reflexes. Your startle reflex.
Are responsible for helping you track moving objects. So when you're undertaking some kind of dynamic movement, these semicircular canals actually contact those corpora quadrigemina and tell the eye to move in such a direction so that you can keep track of the things that are moving while you are moving. Because since you're moving, it seems like everything around you is moving, but in reality, everything's staying in place. It's just your movement. So your eyes are trying to keep track of those things that are not moving. Now, say you were at the top of a hill and you rolled down that hill, and at the bottom, you get down to the bottom and you try to stand up and you're super dizzy and you're falling over. So this all has to do with these semicircular canals. These semicircular canals are picking up momentum as you're going down this hill. They're spinning the fluid inside of it. And so the kinetic energy is building up inside this fluid, and it's causing the fluid to continue to circulate even when you have stopped rolling down that hill. So this fluid is continuing to circulate through, and it's pushing that capillum, and it's telling your brain that you're still moving even though you're not. So it's telling you that you're moving, it's causing you to be dizzy, and at the same time, it's contacting those eyes, and it's causing them to dart across your face. So the classic, oh, I just rolled down a hill, and then you're looking up at the sky, and the sky's spinning around your head. It's not really spinning around your head. What is spinning around your head is your eyes, because these semicircular canals are contacting the corpora quadrigemina and telling your eyes to keep track of everything as you're moving. but you're not really moving. It's just the kinetic energy inside of the fluid in your semicircular canals is still there.
Any questions?
Friends,
So the corpora quadrumina is keeping your eyes, allowing your eyes to focus on moving objects or stationary objects as you're moving. Based on the sensory information within the semicircular canals. Questions? That's the last of this chapter. Let's spend the next hour talking about muscle. If you're interested, there are a few more video links there with regards to hearing and balance. So the muscular tissue, chapter 11, overview of muscle tissue. Body movement results from the alternating contracting and relaxing of muscles. The skeletal system provides a leverage and a supportive framework for this movement. So your bones work as levers that your muscles act upon. Myology is the scientific study of muscles. Different types of muscle. Skeletal muscle is found throughout the body and is attached to the skeleton. Another type of muscle, cardiac muscle, only found in the heart. And smooth muscle found within the walls of thoracic and abdominal viscera and surrounding blood vessels. Skeletal muscle tissue attached to the skeleton. Its function, it's involved in motion, walking, running, maintaining posture, producing heat and thermal regulation, shivering. Its appearance, it's got peripherally located nuclei. And it's striated, it's got alternating light and dark bands observed under the microscope. It's voluntarily controlled. Also, to some level, it's involuntarily controlled. For example, with your one of your skeletal muscles is your diaphragm. How often do you need to consciously tell your diaphragm to contract and relax so that you can breathe? Muscles for posture, your anti-gravity muscles. Maintaining posture, involuntary. Cardiac muscle found within the walls of the heart. Function, it pumps blood. There's one centrally located nucleus. It's striated. and it's got intercalated discs. So how, if you're looking at a histological slide of cardiac versus skeletal muscle, how do you know the difference? What the major way that I can see the difference anytime that I'm looking at one muscle tissue versus another are the intercalated discs. These are specialized gap junctions that join neighboring fibers together and allow for direct communication between the cells. Gap junctions meaning they're tunnels that allow for solutes and ions to move from one cell to the next. This is what allows cardiac muscle to synchronously contract and relax at one time. It's involuntarily controlled, displays autorhythmicity. You do not need nervous system input in order for the heart to contract. However, it will speed up and slow down when influenced by neurotransmitters and hormones. See, when you watch those videos on the autonomic nervous system, the heart by itself can maintain an autorhythmicity. It's actually a little higher than your average heart rate is, because your parasympathetic nervous system slows it down. So 2 ways histologically to tell the difference: centrally located nuclei in cardiac muscle and the intercalated discs is how I distinguish them. Smooth muscle tissue found within the walls of blood vessels and hollow internal organs and structures, for example, the gastrointestinal tract. Also attached to the skin, but to hair follicles. This is what allows you, the contraction of this smooth muscle in your skin allows you to develop goosebumps. Function, it's involved in peristalsis, movement of substances through a tube. For example, your gastrointestinal tube or tract, or through fallopian tubes. The egg moving through the fallopian or uterine tubes. Function, it's involved in regulating organ volume. We have little sphincters that are openings between one organ to the next organ. One example, your cardiac sphincter of your stomach. There's a little sphincter right here that prevents the acid and the partially digested food from moving from your stomach into your esophagus. If you've ever dealt with heartburn, fortunately, I've never had heartburn, but I've heard it's kind of miserable stuff because it's the acid within your stomach moving through the sphincter into your esophagus. In smooth muscle, there's one centrally located nuclei. It's smooth, it lacks striations. It's involuntarily controlled. It's regulated by the autonomic nervous system and hormones. This picture is just a comparison and contrast between the 3 different types of muscle. I'm not going to read through all of it, but I would read through it on your own time. majority of this chapter talks about skeletal muscle. Towards the very end, we'll talk a little bit about smooth and cardiac muscle. Each skeletal muscle fiber is going to arise from fusion of 100 or more myoblasts. When a cell name ends in blast, what kind of cell is that? Blast means a building cell. Myo means muscle. So a myoblast is a progenitor cell that's going to become skeletal muscle. So each one thing, let's actually. So myo means muscle. Another one that we'll see here in a minute is sarco, means muscle. A muscle fiber is a muscle cell. So myo means muscle, sarco means muscle. And anytime you see the word muscle fiber, it means a muscle cell. So each skeletal muscle fiber, remember that means muscle cell, arises from, during embryonic development, from the fusion of 100 or more myoblasts. Each one of those myoblasts has its own nuclei. And so a mature skeletal muscle fiber can have more than 100 nuclei. Satellite cells are unspecialized myoblasts that can repair damaged muscle fibers. When necessary, satellite cells will differentiate into mature muscle. Cell division of myoblasts ceases once fusion occurs. So the number of skeletal muscle fibers is set when you are born. You are born with all of the muscle fibers you will most likely have, with a few exceptions. Most of these cells will last your lifetime. So how do you get bigger muscles? I'm guessing that most of us don't have the same muscle size. Our gastrocnemius in our calf isn't the same size as it was when we were a newborn. Muscle growth does not occur because of division of and mitosis of new muscle cells. It's because the same muscle cells that you're born with enlarge. They undergo hypertrophy. where the muscle enlargement is caused by an increasing number of myofibrils within the fibers. So they just, each of your muscle cells, you're born with all the muscle cells, but they can get bigger or smaller based on addition or subtraction of myofibrils. Testosterone, human growth, and human growth hormones stimulate hypertrophy. Questions? Properties of muscle tissue. Muscle tissue is excitable. It's responsive to chemical signals, stretch, and electrical changes across the plasma membrane. It's conductive. There's local electrical changes that trigger a wave of excitation that travels along the muscle fiber. The muscle cells can generate and propagate action potentials. Remember what an action potential is, that quick depolarization and repolarization. Muscle tissue is contractile. It has the ability to shorten when stimulated. There's two basic types of muscle contractions. There's isometric muscle contractions, where the muscle develops tension but doesn't shorten. The muscle will develop the force but not shorten in length. Isometric meaning the same length. The same metric length. Isotonic meaning the muscle develops enough tension that the muscle shortens and maintains the same amount of tension. Isotonic meaning that the tension stays the same, but the length of the muscle shortens. Muscle is extensible. It's capable of being stretched between contractions without being damaged. It's got elasticity to it. It can return to its original resting length after being stretched. Which of the following is not a function of skeletal muscle?
A.
Say it one more time.
A.
Why do you think it's A?
Because you were earlier, like the skeletal muscle is like walking in motion, maintaining posture. You also use it to regulate, like to move substances through your GI tract. It doesn't.
No, how do you use it? How do you use it to move substances through your GI tract? Is that smooth muscle or skeletal muscle?
Oh, that's smooth. So D.
It's D. How is muscle organized? There's a sheets or bands of fibrous connective tissue that are deep to the skin and surround muscles and other organs of the body. This fascia, actually what we call the epimysium also. And above that, above the fascia, is a subcutaneous layer that stores fat and separates muscle from skin and protects muscle from trauma. This fascia lines body walls and limbs, holds muscles with similar functions together, and allows for the free movement of muscles. It carries the nerves, blood vessels, and lymph vessels. It fills up spaces between muscles. And it gives me its characteristic grain. So it's essentially grouping muscles together. It's kind of the sheet of connective tissue that groups muscles together of particular functions, allowing for free movement of muscles and independent movement of muscles. Or independent of muscles, movement of muscles that perform similar functions. Remember that a muscle fiber is synonymous with a muscle cell. The sarcolemma is the plasma membrane of a muscle fiber. Do you remember what a neural lemma was or an axolemma was? What's a neural lemma?
Oh, is it like a nerve fiber?
You're close. It's the plasma membrane around a nerve. An axolemma is the plasma membrane around the axon. Actually, let me backtrack. A neural lemma is the most outer layer of the myelin. Axolemma is the plasma membrane around the axon. So a sarcolemma, because sarco means muscle, is the plasma membrane of a muscle fiber. Sarcoplasm is the cytoplasm of a muscle fiber. Myofibrils are long protein cords occupying most of the sarcoplasm. Glycogen is the stored glucose carbohydrate for ATP synthesis. Myoglobin, if you think hemoglobin, myo meaning muscle, myoglobin is a derivative of hemoglobin that specifically binds oxygen in muscles for ATP production. Just like the hemoglobin that binds oxygen and transports it in the blood, myoglobin stores oxygen for ATP production in the muscle. It's what gives muscle its red pigment. Dark muscles, red muscles, dark meat, we just finished Thanksgiving, dark meat has more myoglobin in it, which is what gives it its dark texture. White meat has less myoglobin in it. We'll talk about, and you can think about why would one type of tissue have more myoglobin than another type of tissue. Mitochondria lies in rows and is located close to the contractile muscles. What is the function of the mitochondria? It's a powerhouse for cells. It's what produces ATP. Well, where do we need ATP? A lot. We need it in the muscle. So we have lots and lots and lots of mitochondria in muscle. The more a muscle, the stronger a muscle becomes, the more mitochondria it needs. So it's embedded within the muscles, allowing for ATP to be produced as quickly as it's needed. The sarcoplasmic reticulum is a smooth, specialized smooth endoplasmic reticulum that forms a network around each myofibril. If dilated end sacs of the sarcoplasmic reticulum, which cross the muscle fiber from one side to the other and act. This sarcoplasmic reticulum, oh, let me start, terminal cisternae. Here they are. Here's the sarcoplasmic reticulum, the blue here, that lines and forms a network around the muscle fibers. Here's one complete muscle fibril. And around each myofibril are this coat and this network of sarcoplasmic reticulum. And on the ends are the terminal cisternae, the dilated end sacs. This sarcoplasmic reticulum acts as a calcium reservoir and releases calcium through channels to activate contractions. So let me backtrack just for a minute because this is going to be important later. The sarcoplasmic reticulum is your storage of calcium that is required to activate contraction. Transverse tubules or T-tubulars are the tubular enfoldings of the sarcolemma, tunnels that form into the plasma membrane through which, so here, remember, here's the terminal cisternae. In the middle here is the transverse tubules. So the transverse tubules are tubular enfoldings that tunnel into the plasma membrane, the sarcolemma, and allow for action potentials to travel and spread throughout a muscle fiber. So the pair of terminal cisternae with the transverse tubule in the center is termed as being a triad. Myofibrils. Myofibrils are contractile organelles of skeletal muscle. They contain the thin and thick myofilaments arranged in units called sarcomeres. Sarcomeres are the functional unit of muscle. So myofibrils, this little thing right here, starts here and goes all the way back, is one myofibril. Each section from right here to right here, right here to right here is a sarcomere. So this all the way back is a myofibril. each section is a sarcomere. Within each section, there is an arrangement of thick and thin myofilaments. You can see them here. Here's one, here's another. There's an arrangement. The striations of the thin and thick filaments make the muscle look striped or striated. So sarcomeres are compartments of arranged myofilaments, which extend from one Z disc. Here's a section of a myofibril. Here's one sarcomere. Here's another sarcomere. Here's the next sarcomere. They're attached from end to end throughout the myofibril by their Z discs. Each span from one Z disc to the next is one sarcomere, which is the functional unit of muscle. Which structure within the sarcomere releases calcium to trigger muscle contraction, or stores the calcium that will trigger muscle contraction?
The sarcoplasmic reticulum.
Correct, correct. Calcium, this is a question that I'm going to ask you again later. Why does calcium have to be actively transported back in and out of the sarcoplasmic reticulum? Keep this question in the back of your mind. There are three types of muscle proteins that comprise myofibrils: contractile proteins, regulatory proteins, and structural proteins. The contractile proteins cause muscle to shorten when they interact with one another. These contractile proteins are the myosin and the actin. Regulatory proteins regulate the interactions between the contractile proteins, the myosin and actin. These regulatory proteins are the tropomyosin and the troponin. We also have structural proteins that keep the myofilaments in proper alignment and give the myofibril its elasticity, and link the myofibrils to the sarcolemma. Remember, the sarcolemma is the plasma membrane, the outer cellular membrane. This is going to be important for later. These different structural proteins, we have a protein called titin, alpha-actinin, myomesin, nebulin, and dystrophin. So myofibrils are bundles of protein myofilaments, thin and thick filaments. Here's your thick filament, which is myosin. Here's your thin filament, which is actin. Here's a thin filament. Here's a thick filament. You can see that they're overlapping. These myofilaments are surrounded by sarcoplasmic reticulum and mitochondria. Their striated appearance is due to the orderly overlap of the thin and thick myofilaments. Right here, we have thin and thick filaments together. Right here, we just have thin filaments. Thin and thick together, thin filaments. The thick myofilaments are made of several hundred myosin molecules. Each molecule is shaped like a golf club, with two chains intertwined to form a shaft-like tail. At the end of each of these golf club-like shaped myosin molecules, there's a double globular head. So the thick filaments are made out of several hundred myosin molecules grouped together, with the globular heads being pointed out in a helical array. These globular heads function as motor proteins, converting ATP, a potential energy source, to motion, a kinetic energy source. The thin filaments, in contrast, are actin. The actin is made of two intertwined strands of fibrous actin. And each of the filaments is made out of spherical globular actin subunits. And each of the actin subunits has an active site that can bind to calcium. I can't believe I just said that. Let me backtrack just for a second. Each actin subunit has an active site that can bind to the myosin head. In relaxed muscle, these active sites that bind to the myosin heads are blocked by tropomyosin. So we have this intertwining of these filamentous actin. And within this intertwining of two filamentous actin threads is tropomyosin, which surrounds them. And the tropomyosin is overlaying the active sites where actin binds to myosin. And on these strands of tropomyosin is this component, troponin, which can bind to calcium. The troponin and the tropomyosin, these regulatory proteins, act as switches that determine when the the muscle fiber can or cannot contract. Contraction is activated by the release of calcium into the sarcoplasm from the sarcoplasmic reticulum. And when that calcium is released into the sarcoplasm, it binds to troponin. Here's the troponin, here's the tropomyosin. When the troponin binds to calcium, it changes shape of the troponin. Troponin changes shape. When that occurs, it changes because it kind of, let's say it's up straight, it's attached to the tropomyosin, it's straight up and down. When it binds to the calcium, it bends over. At that point, because the tropomyosin is attached to the troponin, the tropomyosin gets shifted too. And it moves off the active sites in actin. When the tropomyosin gets shifted, now the active sites on actin are exposed to the myosin. Another structural protein that we have is titin. Titin is this huge springy protein that Titan, if you remember, the name Titan comes from the Greek god who was known for his strength. My niece has a pit bull named Titan. Big dog. If you've ever played tug of war with a pit bull, it's a lot of fun, but you got to stay on the ground because they'll pull you off your feet. I've learned to, I used to play tug of war with my friend's pit bull, and I learned to just lay down on the ground because the pit bull would just drag me around.
Mm.
But so titin is this huge springy protein that runs through the core of a thick filament. And it attaches that thick filament to the Z disc. So from right here to right here is a sarcomere. Here's the thick filaments. Here's the titin that attaches the thick filaments to the Z disc. Here's the thin filaments up here. So the titin is going to help stabilize the position of the thick filament, and it provides the ability to stretch, giving muscle its extensibility, and provides recoil to give muscles their elasticity. The Z disc is made mostly of a protein called alpha actinin. Remember, from right here to right here is one sarcomere, and that's the functional unit of muscle. The M line, which I like to think of M line as meaning the middle line because it runs down the middle of the sarcomere, down the middle of the thick filaments, or runs perpendicularly to the middle of the sarcomere and the middle of the thick filaments. The M line is made up of accessory proteins, which include myomessin, C proteins, and creatinine kinase. And it's connected to the titin also that runs to the core of the thick filament. Another structural protein, nebulin, wraps around the entire length of the thin filaments and helps to anchor the thin filaments. Remember, this is the actin, the thin filaments, to the Z disc. Here's the Z disc, here's the M line, here's the thick filaments, here's the titin, here's the thin filaments, and wrapped around the thin filaments is the nebulin. And one more structural protein, dystrophin. Clinically, it's the most important non-contractile protein in muscle contraction. It links actin, the thin filaments, to the outermost, links the actin in the outermost myofilaments to the plasma membrane, or the sarcolemma, which links it to the endomysium, the covering around each myofibril. This is crucial, and you'll understand why here in a moment, because you're probably more aware of its function than most things. It transfers forces of muscle contraction to the connective tissue, overlying connective tissues. And right here, that it connects the actin to the sarcolemma, connects it to the overlying connective tissue, the endomysium. Helps to transmit tension. Why do we care about dystrophin? Because of Duchenne's muscular dystrophy, which is a mutation caused by a mutation in the dystrophin gene. Without this dystrophin gene that attaches the thin filaments to the plasma membrane, sarcolemma, to the endomysium, there is no reinforcing effect of that dystrophin protein, which allows for the sarcolemma to tear easily during muscle contraction. And as a result, muscle fibers easily rupture and die. Any questions so far? So the striations are alternating A bands and I bands. The A bands are dark. The A bands are specifically the myosin filaments, the thick filaments. Here we're looking at a transmission electron microscope picture of relaxed skeletal muscle. Here's the A band. Here's the I band. I bands are just the thin filaments. Only the thin filaments. Keep that in mind here. The A bands are myosin. The I bands are the thin filaments only. The M line runs through the middle of the A band. The H band right in here is only the thick filament. So I said the I band was only the thin filament. The A band is the length of the thick filament. It also, because you can't see them, the A band can also include any overlapping thin filaments. But the H band is just the thick filament. So sarcomeres extend from one Z disc to the next and are the functional contractile unit of myofibrils. These Z discs from right here to right here are going to attach neighboring sarcomeres and separate one sarcomere from the next. They provide the anchorage for thick filaments and tighten. The A band, which stands for anisotropic, is where the thick filaments overlap with thin filaments. Here's your A band. Here's your A band. The H zone, which isn't as dark, is the middle of the A band and is composed of only the thick filaments. And the M line is the middle of the H zone. Or the H band. Keep those as interchangeable words. The I band contains thin filaments and no thick filaments. I band right here to right here. The Z discs bisect the I bands. The letter I means thin. It's only the thin filaments. H is, letter H is thick, includes only the thick filaments. One thing that helps also is to remember which is the A band and which is the I band. A, the word dark has an A in it. So the A band is the dark band. The word light has an I in it. So the light bands are the I bands. This is just a review looking at some of the different structural levels of the muscle. Any questions so far? Spend the last 5 minutes going through a little bit more of this. Starting with muscle contraction. Stimulus for muscle contraction. Skeletal muscle never contracts unless it's stimulated by a nerve. And the somatic nervous system, which includes the somatic motor neurons, is what innervates skeletal muscle. If muscle connections are severed or poisoned, the muscle becomes paralyzed. There's a shrinkage of the muscle if the muscle remains disconnected, if the nerve remains disconnected, called denervation atrophy. Relaxation will occur when the nerve impulse stops. Motor neurons and motor units. A motor unit is defined as one nerve fiber and all the muscle fibers innervated by it. A nerve has to come in physical contact with a muscle fiber or muscle to innervate it. Muscle fibers of one muscle unit. Remember, a muscle unit is all of the fibers and the muscle nerve fiber that innervates them. So the muscle fibers of one motor unit are dispersed throughout the muscle and they contract in unison. They either contract fully or not at all. It's this all or none law. They produce a weak contraction over a wide area. The muscle motor units can provide an ability to sustain a long-term contraction as different motor units within a muscle take turns contracting. An effective contraction usually requires the contraction of several units at once. When a given lower motor neuron fires an action potential, how many muscle cells within that in a motor unit will contract? The answer is all, because it's an all or none law. They will all contract at once. We have small motor units and we have larger motor units. Small motor units have a fine degree of control. These smaller motor units, maybe one neuron innervates 3 to 6 muscle fibers. Some examples are the muscles of your hand and eyes. These are involved in fine control of muscle function. Large motor units are more for strength than control. They provide powerful contractions that are generated by hundreds of motor units with hundreds of fibers innervated. For example, your gastrocnemius of your calf muscle has 1,000 muscle fibers per neuron. Do you have any questions for me? We will definitely finish this chapter on next Friday, and I will work to go over some of the autonomic nervous system. Have a wonderful day, okay?
Thank you. You too.
Bye. Have a good weekend.
You too. Gervine or Morgan or Braden or Ariana or Abby, are you here? Okay, I'm going to end the meeting.